All right, everyone. Good afternoon. Thank you so much for joining us. I am so pleased to have Linda Couch with us here today. Linda is the Senior Vice President for Public Policy at LeadingAge, our national organization, and she's responsible for developing and leading the overall strategy for public policy, legislative, administrative, and advocacy agenda. And so I'm going to turn it over to Linda, allow you to introduce yourself and share the great work that you and your team do to support your members in DC and around the country.
Sure. Thanks, Makita. And yeah, we are your DC office. We're your legislative and congressional office for the federal agency policy. So happy to be here. We work closely with Makita, obviously. And yeah, so I'm here. I have a slide deck prepared, Makita, to go through some of the hot topics, big things that have happened this year and things that we're looking to the future for across the aging services continuum, right? So I have news and updates about home health and affordable housing, nursing homes, et cetera, et cetera. And so before we get started, it'd be really helpful for me if folks don't mind if people introduce themselves so I understand where you're from and the kinds of services you provide, if folks don't mind.
I can start. I'm Diana
Thanks, Diana.
Nazario. I am the director for the Shippensburg Senior Center, Branch Creek Place. We serve our members in Shippensburg Monday through Friday. Activities, we serve lunch every day for $3. We're open from 8:30 to 3 o'clock daily. We also serve our local Meals on Wheels program. We serve about 56 to 60 members that are homebound.
Perfect. Thank you.
You're welcome.
Would anyone else like to introduce themselves? All right, Makita, I think with that, I can go ahead and get started. I'm going to share my screen if that's okay with you.
Yeah, please go ahead.
Okay. And I can send these screens, these slides to you, Makita.
Thank you.
And then you can share them. So yeah, so this is the slide deck, and I think you all are LeadingAge members, but even if you are not, so our mission here at LeadingAge is to be the trusted voice for aging, and our vision is an America that values older adults and those who serve them. And of course, we talk quite a bit, not just about the needs of older adults, but about the providers who work every day to try to meet those needs as best they can. And a lot of the resources that providers receive to try to meet those needs are federal resources from the federal government. And those programs have rules and regulations and guidelines, some of which are statutory, done by Congress, and some of them are regulatory, done by the executive branch and the federal agencies. And so not only do we fight to make sure the money is there at the federal level, but we also work to make the programs better, whether that's through statutory or regulatory changes as they're needed, but all in the focus of our mission and vision. We have LeadingAge DC, of course, is our standout state partner, but we have another cache. We have 36 state and regional partners, and this is a pretty map that came from our membership team. And Makita, I was with Megan when she was sharing this slide a few weeks ago from our membership team, during which time Megan realized that Alaska and Hawaii are not on this map at all. So this slide is going to get updated because we do know that there are 50 states, but we don't have state affiliates in Alaska, but we are very close to having one in Hawaii. So this year, looking back, one of the big things that happened is HR 1. And that was a bill that got passed and signed into law. It's been often referred to as the One Big Beautiful Bill Act, and people have lots of other names for it. And on its face and at its inception, this was pitched as a tax cut bill, right? This was the bill that would extend all the 2017 tax cuts that were up for expiration this year. This is a bill that would add in other tax cuts, including those that then candidate Trump pitched during his re-election campaign. And so this bill is chock full of tax cuts and some other spending. So there's about, all told, somewhere in the neighborhood of $4.5 or $5 trillion in tax cuts and other spending. And while most of that is tax cuts, there is spending in this bill to pay for increased deportation and immigration and border control efforts. There's some money in here for the Defense Department, but most of the $4.5 or $5 trillion spending over the next 10 years in this bill is to pay for these tax cuts. But there was a lot of hesitancy on the Hill to increase the deficit by that much. And so fiscally conservative members really held firm that they wanted some offsets. While this bill was going to spend a lot of money, they also wanted it to save a lot of money. And because the process that they used to pass these tax cuts, this process of budget reconciliation, only allows certain kinds of cuts to happen. And President Trump said that Medicare cuts were off the table. Budget reconciliation doesn't allow Social Security cuts. It doesn't allow cuts to discretionarily funded programs like HUD programs, for example. And so we knew really the day after the election last November that Medicaid had a big target on its back to provide a lot of the offsets that fiscally conservative members of Congress wanted to see in this One Big Beautiful Bill Act to carry their tax cuts through. And so this bill achieved those goals, to be sure of that. And overall, the bill, we see this bill as a healthcare bill. This bill will cut healthcare funding over the next 10 years by about $1 trillion. Most of that cuts of federal funding to states for Medicaid, and then some of that from cuts of federal funding that without those cuts would have gone to the Affordable Care Act marketplaces. In total, the bill is expected to cause the loss of healthcare insurance by more than 11 million people over the next 10 years, and really puts a lot of pressure and threat on home and community-based services, which are optional services under state Medicaid programs. And so when states are going to be faced over the next many years with how do they absorb these cuts, they don't have a lot of choices, right? They can look at cutting optional services like home and community-based services. They can look at cutting rates, right? Like, so cutting provider Medicaid rates or some combination of those. The bill did increase the deficit so much that it would have triggered an automatic cut to Medicare. But thankfully, in the shutdown fix bill that Congress just passed last week, that bill waived that Medicare cut from coming to be next year. So that's some good news. So we're going to dig in a little bit to this One Big Beautiful Bill Act, but I think the most important things to know about the Medicaid changes is that it makes Medicaid harder to get and it makes it harder to keep. And its provisions are different for the Medicaid expansion states versus the non-expansion states. And DC is a Medicaid expansion state. And that just means that under the authority of the Affordable Care Act, states were allowed, if they wanted to expand their Medicaid programs to people above the federal poverty limit. And 40 states, most states decided to do that. So most states have expanded their Medicaid programs, and the bill really twists the knife financially on states that are these expansion states through new eligibility determinations, through work requirements, and through retroactive eligibility, which I'll talk about. So these are the eligibility changes, and then we'll talk about some financial changes. So first is these eligibility changes. So under this bill, people will have to redetermine in states. So DC is going to have to set up a system at least every 6 months. DC will have to redetermine people's Medicaid eligibility, and enrollees will have to redetermine their Medicaid eligibility, which of course is going to cause some people not be able to comply with that, and they will lose their eligibility. The bill also makes some big changes, and this is just for these expansion states, to retroactive eligibility. Under current law, if someone applies for Medicaid, and they are found to be eligible for it, their Medicaid coverage is retroactive for 90 days before the date of their application, right? That recognizes that it takes a while for people to know that they need Medicaid, qualify for it, find the paperwork, get their application together, all those things. And so right now, there's retroactive Medicaid eligibility for 90 days from the date of application. For expansion states, including DC, this bill now says that retroactive eligibility only applies for 30 days prior to the date of application. So it's going to be really important for providers and other stakeholders to help get those applications in as quickly as possible, even if they're incomplete, if the state will agree to accept incomplete applications so they can be finalized and filled out fully a little bit later. And we've all seen this in the news. The bill has work requirements for the expansion population. And this is new, right? Medicaid does not have work requirements. Did not until now. These will go into effect the end of next year. And so that's really soon. So states between now, DC, between now and the end of next year, has to stand up a system where all the people in that expansion population are going to have to certify that they are working or in school or volunteering for at least 80 hours a month. And we know that a lot of this expansion population is probably not in the older adult population, but it really very well could be in the people that work in our provider communities, or members of older adults' families who they rely on to help them with whatever it is they need help with. And so these work requirements are another way that the bill will inevitably shrink the number of people who receive Medicaid. And then in addition to those eligibility changes, right? So more frequent redeterminations, new work requirements, and this retroactive eligibility time period shrinking, which is going to lead to probably more uncompensated care for providers. The bill makes some important financing changes. And the one I'll mention is probably the biggest one, and that those are provider taxes. Like most states, DC has provider taxes. Makita, as best as I can tell, that's the case. And the bill forces expansion states to decrease the tax, the provider tax, to 3.5% from whatever it is now, and the cap is at 6%, down to 3.5% by 2032. Congress really painted these taxes as a scheme, but they are quite legal. They're on the books. All states but one use them. It's not a perfect way to pay for Medicaid, but it is the way that everyone does it. But Republicans really painted this as a scheme and as fraud, a scam. And so this is where a lot of the cuts to federal funds going to states for their Medicaid programs are going to come from. All told, over the next 10 years, the Kaiser Family Foundation predicts that DC will see about a $3 billion decrease in federal Medicaid dollars coming to the city. So that's a big number. And so DC will have to figure out how it reacts to that, right? Will they cut optional services? Will they cut provider rates? Will they cut access to staff or what have you, but DC is going to have to backfill where they increase taxes. So DC is going to have to figure out how it addresses those cuts because of this bill. The bill also, and we know the food stamp program has been in this turmoil during the shutdown. And that seems to have been fixed, right? This new shutdown bill fully funds SNAP, the food stamp program, through September of next year. But that aside, this bill, HR1, this one big beautiful bill, makes some huge changes to the food stamp program that will carry on for the next 10 years. And two changes I'll mention. One is that right now, the states and the feds share 50-50 the cost of um, the administrative costs of the food stamp program. And there's a typo here, but instead of it being a 50-50 split, DC will now have to pay 75% of its oh no, it's there. I did it right. Of its administrative costs, up from 50%. So that's DC spending more money, which it never has had to pay before. And then that's just the administrative costs. But right now, for the food stamps, the actual benefit, the federal government pays and has always paid for the entire federal government. There's no cost share like there is in Medicaid. But HR1 sets up a cost share for the benefits. And it's the amount of the share that states have to pay is based on their error rate in the food stamp program. DC has a very high error rate. It is so high that they're kind of given a pass until 2030. But in 2030, if DC doesn't lower its error rate, it's close to 20% now. If it doesn't lower its error rate to 6%, DC is going to have to kick in 15% of the cost of SNAP benefits. And I say that because we're really looking at a zero-sum game here. Whether or not you work with people who rely or need food stamps, either older adults or people on your staff, DC is facing all these costs that are going to be a cumulative effect on the resources it has to meet all of the city's needs. Lots of other provisions, and this bill is a huge bill, and I'll share these slides again through Makita. One big thing in this bill is it placed a moratorium on the CMS minimum staffing requirements for nursing homes. So that's been something that's been going through the court system and Congress. There have been bills and other vehicles to try to stop it. In the court systems, after this bill was passed, the courts finally, the CMS backed off. They're not appealing any of the courts. So it's dead as far as the courts are concerned. Congress placed a moratorium on these staffing requirements, and there's a rule sitting at the Centers for Medicare and Medicaid Services, which will finally repeal the rule. But regardless, because of what's happened in the courts, the staffing rule has been repealed and reversed as far as the minimum hours go. So as far as the 24/7 RN requirement for nursing homes, and the other minimum staffing part of that, which was the having to have 3.45 hours per resident day of staff on the clock. So we're relieved about those. We can get back to what we should be focused on, which is increasing payments for providers and increasing the aging services workforce. Nursing homes are going through a lot of other things too. CMS, since like the January, since this administration started, has been under a communications freeze, right? They put out press releases and they're in the news. But as far as communicating directly with associations, with providers, they stopped that in January and have not restarted that. And so any kind of, questions that we have on behalf of members or other kinds of things, it's very time consuming and frankly painful for us to get those answered. We do know, though, that CMS has ramped up its nursing home staffing campaign, and they said they're going to roll this out in the spring of 2026. And a couple of components that we're aware of are tuition reimbursements and stipends. So for both RNs and LPNs. So we think that that's great news there coming, we hope, in the spring on the nursing home staffing campaign. And CMS recently announced that they are making revisions to the civil monetary penalty reinvestment program. We've been working on those revisions for quite some time. There are bills in the House, right? These are all big nursing home bills to get more CNAs to be able to be trained, to end the 3-day stay requirement, and to address the lack of resources at long-term care provider communities, to address the lack of resources they have for health information technology. Medicare Advantage has also been in the news a lot and is a big deal for LeadingAge and all of our members, right? More than half of Medicare beneficiaries are now in a Medicare Advantage program rather than in the traditional Medicare fee-for-service program. And so generally, we have been working both on the Hill and at HHS, CMS on 3 broad planks around Medicare Advantage. One is on payment adequacy. We know that MA plans do not pay what fee-for-service pays and do not pay what providers need to cover their costs. A second is that we need to reduce the administrative burden of partnering with managed care plans. The forms, the prior authorizations, all these things are way over the top, and studies have shown plans place significantly more burden on post-acute care providers than they do on the rest of the healthcare systems. And then we want accountability and transparency, right? We think that these plans should be held accountable and should be clear about the money coming in and the money going out. But interestingly, there's also a bill in the House that would make Medicare Advantage the default way that everyone gets their Medicare. We strongly oppose that. We don't think that's a good idea. And so we're working with that office and others to make sure they know that that's a bad idea. Lots of movement in home health. Home health has been under the knife for the last several years. And right now there is there's a proposal that we're waiting any day now to come out of CMS to finalize how much Medicare home health payments will go up or down next year. CMS has proposed a 9% cut, and that's on top of an almost 10% cut since 2023. And so another 9% cut would be, we think, really devastating for nonprofit home health agencies. And we are working, of course, with CMS to push back on that, but also on the Hill to stop any additional cuts from going into place. Affordable housing is another big deal for LeadingAge members. There was some other good news in HR 1, so a lot of bad news in that bill, but there was some good news, and that bill increases state allocations of low-income housing tax credits. So very good news. The district will see a bump up, and that bill also lowers the need to secure bonds as part of tax credit deals, and lowers the bond threshold to free up more private activity bonds so they can be used in other projects in addition, and not just get sucked into to a small cadre of tax credit projects. Besides the low-income housing tax credit program, we have a huge focus on HUD appropriations because a lot of LeadingAge members use and rely on HUD programs like Section 8, project-based rental assistance, or Section 202, housing for the elderly, housing choice vouchers, and homeless assistance through the continuum of care funding. And that appropriations bill for the fiscal year that we're currently in is still under discussion and debate. And we are working to make sure that Congress passes a full year FY26 bill because we need those funding. Another problem that's come up over the last several weeks is this administration's shifting focus and how it funds homelessness funding. Most homeless assistance programs use most of their money to fund permanent housing through a housing first model that basically says, let's get you housed first, and then we'll figure out all your other needs. So mental health, behavioral health, services, healthcare, whatever it is, but let's get you housed first and get you into permanent housing. Well, the administration does not think that that's the right approach, really backtracking on not only evidence, but 10 or 15 years of practice, and is significantly curtailing the amount of homeless assistance funding that can go toward permanent supportive housing, leaving current permanent supportive housing providers really in the lurch for how they're going to make up those dollars for next year, which is a big problem because older adults are the fastest growing population within people experiencing homelessness. I mentioned the aging services workforce before. This is a huge issue for LeadingAge across all the different service types. It's a math problem. We simply do not have enough people to be in the workforce in this country to meet the needs that we know we have for our older adult population. Just the math doesn't work. It's not about the quality of the people or their abilities. It's about we just don't have the bodies to join the workforce. And so for years, we've been working on immigration solutions to bring more foreign-born workers into this country so that they can be in the aging services workforce. And we're working on things through the administration, but also a suite of bills on the Hill that would create more and legal pathways for people to come here and work here. And then just looking ahead, as I mentioned, this home health final rule, we're desperately waiting on that. The new shutdown fixing legislation ends January 30th. And in that bill, I mentioned HUD funding, we need to get that figured out, but also telehealth extenders, right? The ability that COVID gave us or gave providers to perform telehealth needs permanent extension, and we hope that'll get done. And then the Older Americans Act programs, those fund a lot of transportation and nutrition programs, and that overall act through which all those smaller programs and fundings flow, the Older Americans Act, is up for reauthorization, and we're eager to get that extended. Just in general, looking back, it's been a pretty chaotic year. We've seen a lot of rescissions and impoundments, and that just means the administration not spending the money that Congress appropriated, the money that Congress told it to spend. And that's a big problem, obviously, right? If we have an administration that just says, no, I don't want to. So that's a problem, and we've seen that come through with funding delays to aging services providers. I mentioned the lack of communication. That's an ongoing issue. I also wanted to mention deregulation. One of the silver linings we thought and still think that this administration will come through on is deregulating, right? Streamlining things, easing administrative burden, cutting through the red tape. And LeadingAge has submitted more than 130 deregulatory suggestions to HHS, to HUD, Department of Labor, Department of Education, et cetera. And we are still waiting for the deregulation to come. And hopefully it will, but we're not seeing it yet. And then finally, on the federal workforce, right? These programs are big and they're complicated, and they have to get down many, many, many layers of bureaucracy and administrative support until they get to the people that they're meant to serve. And because of that, we really rely on the federal workforce to help us and providers weave through that bureaucratic layering. And the HUD workforce has been cut by more than 30% this year, and the HHS workforce has been cut by more than 30% this year. And so we're eager to sort of stop the bleed on the federal workforce so that we have programs that can work as they are supposed to. Finally, I'll just say, we encourage everyone to join our federal policy conversations. They happen through our multiple member networks. We have, I don't know, around 15 or so member networks depending on what kind of services or provider you are. We have action alerts. We have a weekly national policy pulse call. That's, a listen-in call to hear the latest in policy. And then we have a fantastic learning hub, which is our learning management system, where you can attend webinars or watch videos and kind of get the latest on those kind of knowledge news. And so with that, those are my slides, Makita. I'm happy to take any questions or.
Thank you so much, Linda. Yeah, there's been a lot happening this year. So you all are, I know, always working many times behind the scenes, just keeping up with things, keeping in communication. And I really appreciate all of the work that you all do for us. So yeah, curious to see if there are questions. I know we have a couple of nursing homes on the line, I believe, as well as I heard an HCBS earlier. So.
Yeah, I could start. Good afternoon. Yeah, good afternoon, everyone. This is Chris Scott from Forest Hills of DC. Then the couch. Oh my gosh, a wealth of information. I wish I had that brain of yours on all this stuff. But so appreciate the information. But you talked about mandatory staffing. You talked about the 3.45. Now, for years in the district, it's been 4.1 with 0.6 being RNs and then 3.45 being, CNAs or LPNs. Now, will that change? Is there a change?
Yeah, thanks, Crystal. I appreciate that. When I was saying that, I was like, wait a minute, Linda, doesn't DC have their own? And so, no, it will not change. Whatever DC has will stay on the books. Yeah.
Yeah, thanks for clarifying that. And I did want to, oh yeah, go ahead, Crystal.
I did a follow-up question about the stipend, the CMP penalties, the stipend. Do you know when they're going to make those funds available? And I believe it was going to be for training for you. I think you said registered nurses,
Yeah, so the
LPNs.
registered nurses, so that nursing home staffing campaign is supposed to roll out. So that's they're not going to start training people, but they're going to provide money as tuition reimbursements and stipends to get more nurses into the field, RNs and LPNs, and they say they're going to roll that out in the spring. On the CMPs, we're waiting. The shutdown really, the week before the shutdown, CMS said, we're working on revisions to civil monetary penalties. We're going to increase how much money you can get per activity up to 6,000. We're expanding the types of things you can do with the money. And next week on October 6th, we're going to announce a lot more information. But between then and October 6th, the shutdown came and we haven't heard anything else. So we're waiting.
Thank you.
Yeah. Thank you so much. Great questions, Crystal. Any other questions for Linda? Here in DC, of course, we have our DC Council that LeadingAge DC, along with our partners in the DC Long-Term Care Coalition, work really closely with throughout our session. And so, as Linda mentioned, these changes are impacting DC. They have changed eligibility for the DC Alliance in DC, and they've cut services like dental, and they've lowered the income eligibility from 215% of the federal poverty level to 138. And so I know that those are going to have reverberations for our workforce and for our residents as well. So we will continue to work together and keep everyone informed and definitely keep our DC members informed of when we can expect to have opportunities to testify and go down to the Wilson building and share our experiences and advocate for our needs for this population. But many of it, we'll continue to watch what's happening and see how we can respond.